Well, good morning, Robert. How are you?
Good morning, Chris. I'm very well, thank you. You're looking younger every day, I have to say. Your lifestyle suits you.
Yes, well, it's all sunshine and good food and rainbow diets and golf, I'm afraid. Right, let me just tell a few people about you. You're a former British Oncology Association Oncologist of the Year in the UK. There's a credential for you. You're consultant oncologist at Bedford and Addenbrooke's hospitals. You even teach at our rivals, Cambridge University. But Robert also incorporates nutritional and lifestyle strategies into chemotherapy and treatment of people with cancer to improve their outcomes and reduce their side effects, which I think might summarize it a little bit too succinctly. And we'll talk more about it, I guess. But we're singing off the same sheet, I think, really, from
Yes.
different backgrounds. So as always, I've got a long list of questions. Let me just tell you, we always try these chats are just very simple. They're very kind of casual, and our aim is to give people tips and information to just show them how they might improve their personal odds of survival in this journey that they're on. It's very simplistic. Okay. So I've got a question here. The first one up is on this compound you invented. And we were saying just before the show, we met in Groucho Club to have a chat about it a long time ago. The compound is POMI-T. And I believe you were putting broccoli together with tomatoes and exercise at Addenbrooke's and extending people's time before operation on prostate cancer by 4 years or something like that, wasn't it? The start.
Well, yeah. I mean, thanks for bringing that up. That's probably one of the better trials we've done. I specialize in prostate cancer, so a lot of men come to me, say, I'm taking lycopene, I'm taking saw palmetto, whatever, a whole list of things. And there was, selenium, vitamin E, all sorts of things. So there was some trials to show that some of these things were inappropriate, like saw palmetto, for example, was never shown to be particularly successful. Some actually a bit concerning, like vitamin E was, if anything, could do more harm than good.
Yep. I agree.
So we decided to get a panel together. We worked with the government, we worked with the NCRN, National Cancer Research Network, and various nutritionists. And we came up with the foods which are most likely, based on the available evidence and background research, to have an effect. And so we came up with broccoli, green tea, turmeric, and pomegranate. There are certainly others in that category, but we had to be pragmatic. And we got a company to put it together. And we did, the gold standard study, which was a double-blind randomized study run through the government. It was all independently audited. So all the things doctors and clever people like.
Yeah.
And we were very pleased to see after 6 months, there was a 64% difference in the marker of prostate cancer. And that was written up then in a Nature journal. And we presented it in front of 44,000 oncologists in ASCO, which is the world's biggest conference for oncologists. And it was very well accepted amongst doctors and patients alike, because the research was behind it and people knew it was kosher.
But that's what you do, isn't it? You do quite a lot of research into and conduct your own trials in the stuff around the drugs, if you like.
Yeah, so this was a nutritional intervention. It's not a drug. It can't be prescribed. People have to buy it themselves, so to speak. And what it's showing is those foods, or those type of foods, can, and in fact, it was one of the first trials in a randomized form to show that nutritional intervention can slow a cancer.
Yes.
I mean, that's the fundamental. Obviously, in the general population, people are attracted to supplements. It's a convenient way of boosting these foods, but we're not saying take a supplement instead of a good diet. And even organizations like the NCI in California, if you go on their first page now for diet and prostate cancer, the POMI-T trial comes up #1. So it's reached, high places. And people say there's a conspiracy against supplements and a conspiracy against nutritional intervention. There isn't, as long as the trial's been done properly, which it was. Since then, we had to do a couple couple more studies. We did one because people were saying, well, maybe it just affects the markers of prostate cancer, the PSA, and not the cancer itself. So we did a subsequent trial looking at MRI images of the cancers, and we saw there was a good correlation between the PSA and the images. And then more recently, you'd like this one because you're international, we did a trial in Tokyo looking at, with the Tokyo breast cancer survival group, and we looked at women who had nasty side effects from aromatase inhibitors, tamoxifen, being made prematurely postmenopausal. And we looked at hot flushes, joint pain, and mood. And they took POMI-T, and there was, again, about a 60% improvement in the 3 most common side effects affecting women, to a level of about 20%. So it was about a 20% improvement, and about 60% of women said it helped them. So, you know, another practical intervention they can do when they're usually told by their doctors that, you know, there's not much they can do, or, you know, take these drugs which have other side effects.
Yeah.
So we like that, you know, we like that people can empower themselves. They can go out and take these foods or take the supplement and help themselves. So this is what we like to do.
I think a lot of patients are looking to empower themselves. That's the simplest phrase I could come up to. I mean, they just come along, Chris, how can I help myself? I'm at this point now in my journey. How can I help myself? In fact, I've got the first question. I've got a whole set of questions for you here. We'll try and get through them all. It was from Rick Bower. He said, I've been taking POMI-T and it does seem to have had a positive effect, reducing my PSA count. He said, however, my question is, what effect is this likely having on the prostate cancer, or is it just enabling a lower PSA reading, which could mask underlying developments? You sort of answered.
Yeah. I have. It's worth emphasizing, though. So it's a good question, because obviously that was one of the questions in ASCO, which many people reported. And there are some thoughts that sort of phytoestrogenic supplements could possibly do that. In fact, there was a paper from Riga saying that isoflavones and phytoestrogens could increase the risk of prostate cancer, which was debatable, but it was probably masking a PSA, and maybe people weren't then presenting early enough. So that's why we definitely did not include phytoestrogens in the formulation for POMI-T, for that reason. And anyway, to support that, we then did an MRI study. I mean, fortunately, I am an oncologist and I do have an MRI scan, you know, 2 doors away from me. So we did a study, of a separate study of over 120 patients, where we actually took MRI scans every year while they were on POMI-T. And there was a virtually 100% correlation between PSA. So if the PSA dropped or stayed the same, the tumor didn't change. If the PSA went up, you saw the MRI getting worse. So it's not a masking effect, it's a genuine reduction in the people it works for.
All right, you talked about phytoestrogens. Brian Jones says, POMI-T contains pomegranate. I am on a testosterone lowering drug for my prostate cancer, but drinking pomegranate juice daily for 2 weeks puts up testosterone by 27%. I've got that figure too. So does olive oil. So does lifting weights. So he's talking about putting up testosterone by doing a number of things. Comments, please.
Right, well, you've got to look at the data he's quoting is for people not on drugs to lower your testosterone. If you take Zoladex, for example, your testosterone dramatically drops to nearly 0 levels, which you can measure. So he's quoting people who aren't on testosterone, aren't on these drugs. So if you're on these drugs, there would be virtually no impact on your testosterone levels. That said, it's not correct what he said, I'm afraid. And I was asked to look at a study recently for giving exercise for people with prostate cancer. There's an international study called the Interval Gap 4, which is putting men into a very intensive exercise program, randomized against a further line of drugs to see if that could be as effective as drugs. It's called the Interval Gap 4. So clearly, we're not afraid of exercise. Secondly, when you exercise, your testosterone level does go up for about 20 minutes, but then it drops afterwards. And actually, in fit people, the problem with exercise in the long term, it can lower your testosterone too much. In fact, many cyclists have problems with their testosterone levels and have to, the famous international cyclist who had to give up because he developed osteoporosis and very low testosterone levels because of the level of intensity of exercise he's doing. So it's not actually true that exercise increases. It's only a temporary increase. Thirdly, it's a big surprise that if you have, in a normal person, not someone on drugs, if you have lower testosterone levels, you have a higher risk of prostate cancer, which is strange to understand, because we know that if you have prostate cancer, to reduce testosterone helps it. But as these studies have been done, where they've looked at thousands of people and measured testosterone levels, and the men with lower levels have a higher risk of prostate cancer. So there's a two-phasic solution there. When you've got it, you need to reduce your levels of testosterone. When you haven't got it, you actually need to improve your levels of testosterone.
Yeah, I always remember, in my advertising career, I knew a Mr. Sylvester Stallone, and he used to pump testosterone all the time, and he used to pump iron all the time. And I did actually do a look at bodybuilders who have higher testosterone to see whether they got higher levels of prostate cancer, and they get lower levels of prostate cancer.
Well, I'm not sure about that data, but it certainly I'm talking about people who with lower levels than normal. So the male menopause, they tend to have a higher risk. There are risks of taking extra testosterone above normal levels. There's liver cancer and stuff. But that's a very interesting point, Chris, because men come to me feeling lethargic, depressed. They're on active surveillance. You do a testosterone level and it's low. And you say, and they go to the GP and say, can I have a little bit of testosterone to just put myself up to normal levels? And they say, no, you can't. You've got prostate cancer. You can't. Fortunately, there has been a study done now to show that it's safe to give small levels of testosterone if you're correcting a low level. And it doesn't increase the risk of prostate cancer. And they're even now thinking about it. If you've had prostate cancer in the past and you've had, say, radiotherapy or surgery, and you're suffering from long-term lack of energy, to actually give testosterone replacement. So it's one of those things that many doctors will run a mile if you mention testosterone and prostate cancer. But actually, if you look at the data, it's probably safe to do it.
I know there's a lot of research on testosterone, and as you say, in what condition you are and whether you should have it or not. I mean, you're probably about the same era as me. When I started all this in 2002, 2003, we interviewed the head of prostate cancer at, let's say, one of Britain's top hospitals. And in those days, 2002, 2003, they were giving estrogen injections. And he said to my girl who went and interviewed him, he said, we find that all men with prostate cancer have high testosterone.
No.
And it was just not true.
Well, in his defense, I remember sitting in one of the conferences where the trial was presented, and there was a gasp in the audience because we all expected men with prostate cancer to have high testosterone. It turned out to be the other way around. Can I make a comment about the pomegranate juice, the guy? Actually, that has been looked at. There wasn't any trial which showed that pomegranate juice helps prostate cancer, I'm afraid. Now, the reason why we included pomegranate, because there was a trial of pomegranate seed extract had an effect. Now, pomegranate seed extract has much more polyphenols than the juice. It also doesn't have the sugar the juice has. So squeezing fresh pomegranates is fantastic. I'm not saying doing that. But when you process it and put it in a juice and you buy it over the counter, it does become quite sweet. And I think the reason is the extra sugar is negating the effect of the polyphenols. And that was shown in a trial. There was a randomized trial of pomegranate juice, and it was not beneficial at all. So I tell him to avoid that and just have fresh pomegranates.
I love doing these shows because I'm sure all my listeners who actually follow me must think I've just told you what to say, because I tell people what they can take, and I say, look, you can take the pills, you can go and drink the juice, but the juice is very sweet. I'd rather take the pills. And anyway, I grow them in the garden and we eat them out the garden fresh, and that's better for you.
Yeah, absolutely. If you've got the luxury of growing pomegranates in your garden,
Yeah,
that's what you need
just
to do.
next to the golf course, I grow them. Okay, let's get unnauseous. Gary Senior, I know him terribly well. What is the best type of scan to show where cancer cells are in the prostate? I need to see if they're still there before people start zapping them with radiotherapy.
Well, you can't see individual cells, I'm afraid. You can see a lesion, and they're called PIRAD 1 to 5, which is a code to how certain the radiologist is. So if you had an MRI scan and the radiologist said it's PIRAD 5, it's pretty certain that you've still got cancer there. If it says PIRAD 2, they're not really sure. So MRI is the best one for sure. If you can't have an MRI for some reason, you've got a pacemaker, ultrasounds, transrectal ultrasounds, okay. PET scan is quite good, but the lesion needs to be over a certain size, so certainly not good for very, very small lesions.
Mark Emberton, I haven't talked to him, but Mark Emberton, we've talked to him, and we follow him a bit. He actually about 4 years ago was saying men don't need a biopsy anymore. They can have a multi-parametric MRI.
Well, they do need a biopsy if once the MRI has shown what the cancer is, because you need to know the grade of the tumor, which dictates which treatments are best for that person. But what they're saying is, if you come off the street, say if your PSA is a bit borderline, and you have a good quality MRI, and it doesn't show anything, then actually what we're saying is maybe you shouldn't then but you don't need a biopsy, because even if you've got some cells in the gland, they're going to be very low volume and probably don't need an intervention. So that we're moving towards that. We're not quite there yet in terms of the confidence. If you've got a rising PSA, for example, and the MRI doesn't show anything, should we not do an MRI? It's a bit tricky, because occasionally you get caught out. You don't see anything, you do a biopsy, and then it's full of high-grade prostate cancer. But you're right, the scans are getting better and better and better. I'm certain if it was me, for example, I had a borderline, well, my PSA is 0.1, but anyway, because I take POMI-T and all sorts of other things, probably the same as yours. But if I had a borderline PSA, I would go for a multi-dynamic MRI, and if it's negative, I would hold off a biopsy, to be honest.
Yeah. Okay. All right. Fine. Thank you.
Sorry, Chris.
Go on.
Just what I did this week, I was very excited this week. Not every day I go into work and I get excited these days. Roche, bless them, I've just come up with a thing called a liquid biopsy, a liquid CDX biopsy. And I did my first patient. I had to put it in the FedEx envelope myself because the pathologist wouldn't get involved. You do a blood test. If they filter the blood and they do a PCR examination, and they filter the cancer cells from the blood, and they do basically the biopsy on the blood. It was a real advancement. And so the future might be you don't have a biopsy, you just have a blood test.
Well, you may or may not know, we covered liquid biopsies on Cancer Active about 6 years ago, and they've been coming for 6 years. I think they started doing them in lung cancer first, but okay. I mean, they've certainly been around. It's just one of those things when they're really going to arrive,
Well, there we are. It took 6 years. I did my first 2 this week. So that's how long it takes.
Well, I did actually read, while we're on the subject, I did read a little while ago that you can, in America, they've done a test where you can measure men's glutamate score, and it always is totally proportionate to their Gleason score. So it doesn't give you 3 + 4, but it gives you 7. Okay,
well, yeah, I mean, prostate biopsies aren't particularly pleasant, so any advances to avoid them would be good.
I agree. All right, Peter Mayer said, why does NICE not include HIFU, ablation, brachytherapy, proton beam therapy, or nanoknife in its list of treatments for men with prostate cancer? I had to look it up for someone. It does say radiotherapy and surgery. That's all it says.
Okay, I thought it did have something on HIFU. Maybe it's a separate document. Yeah, HIFU is a tricky one. I mean, Mark Emberton, I have high respect for, and he really, he forged a new treatment entity. But the original trial where they did these, if you had an isolated lesion and you had a bit of HIFU, those patients could, they could also be suitable for active surveillance. So, of course,
I agree with that.
The results are good, but of course they'd be good if you did nothing as well. But it's exciting, and in those small group, if the area is nowhere near the urethra, the toxicity is fantastic, and it does bring the PSA down. And if it was me, I would be attracted to that treatment, I have to say. But the long-term evidence that it actually alters survival or prevents new lesions coming back 5 years later is a little bit lacking, in my opinion. So that's why NICE is sort of not embracing it, because once it's in NICE, basically hospitals have to make it available. So there's a lot of financial consequences of something being in NICE. Proton beam, again, really exciting. Is the data, it's mainly consumer driven. If you look at the long-term toxicity data, is it less? To be honest, most of us think it isn't. Proton's very good for tiny lesions behind the eye next to the spinal cord. I personally wouldn't have proton beam if I had a prostate cancer, not yet. So I think the court is still out. But lovely to embrace this new technology, and we need more research. So that's why it's not in NICE, because it's not mainstream enough yet.
Sometime I will dig it out for you. But when I've been doing this about 2 or 3 years, in about 2005-06, 7 urologists, I'm sure you'd recognize the name, I didn't know who they were, wrote to me and said, you've got a magazine going into hospitals. We would like you to look at HIFU and read up all the research. And they sent me loads of links. And if you think it's good, we'd be very happy for you to champion it. And they even went on to say, because drugs companies don't like it and things like this, and they make £14,000 a year out of drugs. And I mean, it was amazing. Yeah. And they said, please look at it. And I did look at it, and I thought it's a jolly good thing. So I have had it on the website literally for a long time. I have very interesting, this question, because I have 2 brothers, and one is a zillionaire in Bahamas, and he went for a proton beam about 10 years ago, never had a trace since. And his younger brother went to John Jarridge in Louisville. I sent him there. Well, we agreed that that's where he was going. And John Jarridge has done something like, well, this was about 3 years ago, about 1,500 people, and says that he has nil impotence problems, and 95% of people have no incontinence problems, and the other 5% tends to go.
Is this with proton beam you're talking about?
No, the first one was proton, the second one was HIFU.
Yeah, if you've got a small lesion in your prostate and nowhere near the urethra, if you select the patients well, I think it's a good treatment. I certainly would be attracted to it. So,
it's the thing that comes out the top, isn't it?
Yeah, so if it's next to the tube,
comes out the bottom.
Yeah. So,
okay.
It's good. It's sound waves. It's not radiotherapy, so there's no risk of secondary malignancy, which can happen. The trouble is, as it stands, we tend to send people who've relapsed with prostate cancer post radiotherapy, and that group, when they have HIFU, they do get a lot of toxicity. But they're not doing so much of that now, and that's what the patients we saw initially.
And the toxicity is caused from?
Well, if they've previously had radiotherapy, so they're already on a losing wicket, and then they've got relapse in the gland, then they have HIFU, and then they get lots of toxicity after that.
Oh, right.
But you're talking about the people who haven't had radiotherapy, and have just gone straight.
Right,
and that's the group. I think that's where it is good. I think that's a nice niche, to be honest.
Rob Fowler says, you talked about radiotherapy. Rob Fowler says, do you recommend radiotherapy for prostate cancer? And he said, if so, how do you protect potential rectal damage? Now, can I just say, throw my tuppence in here? For about 4 years, I've had people who've told me if they've been offered radiotherapy and they've talked to the doctors about rectal damage, and they've said, well, we're thinking about having a shield, or we're thinking about having what sounds like a pouch of jelly almost. Is anything happening or not?
Yes, I mean, I do prostate cancer, so I spend my day speaking to men about. So we offer them active surveillance, brachytherapy, radiotherapy, or surgery. And as you say, we should be offering more HIFU, but it's not mainstream at the moment.
Yeah.
But I suppose if people surgery, and then the survival rate's pretty much the same with all four. If they go for radiotherapy, then we say, well, how can you reduce your toxicity? So we'll talk about the technical aspect first. The machines have become fantastic. They can bend the beams, they can avoid the rectum and other structures. And it's really, especially if you have to treat the lymph nodes, which is a big field, it's really nice to see now these big fields using these fancy machines. Where 10 years ago, people were having a 20% chance of long-term rectal problems, there's like down to a 5% chance. If you're just doing the prostate alone, it's now about 4% chance of long-term damage, which is fantastic. And that's just due to technology and man's brilliance. You can improve that by putting an OAR spacer, which is a little gel pad between the prostate and the rectum, which pushes it out the way.
How'd you get it in there?
You inject it under local anesthetic. To be honest, if you go privately in the UK, you get that. Probably anywhere in Europe and America, it's routine. They're not funding it on the NHS, mainly because they feel that percentage improvement doesn't justify the cost. But if you had the money, it's probably worth doing. Now, looking at the other factors, which I'm very interested in, I did a study where we got 800 men with prostate cancer, and we looked at their various lifestyle factors and which ones had correlated with a lower risk of rectal incontinence, rectal bleeding, penile incontinence, and waterworks problems. Now, obviously, if you were overweight, that was a risk factor. So if you did have time to lose weight, that's good. Probably because of the inaccuracies of the radiotherapy if you're more overweight. Secondly, smoking. Smoking, the carcinogens in the smoke enhance the toxicity from radiotherapy. So even if you can't give up for good, stop during your radiotherapy. Quite surprisingly, people who exercise more than 3 hours a week during their radiotherapy and afterwards on the questionnaire, they had the biggest correlation between lower side effects. So they were more likely to keep erections, less likely to get rectal damage, and have better waterworks. Now, and that was published. In fact, I won I was showing off a bit, I won the Royal College of Radiologists prize that year for that paper. And so it is recognized. However, how many men, when they go for their radiotherapy, are told to exercise in the UK if they're not outside our cancer unit? Probably nil. So this is a study which has been done. It's shown to help. They can empower themselves. It's just people are just not told that data. So
I've got you'll be interested in this. I've got I think he's 46, got 2 kids. He's in the Midlands, and he had it in his lymph, I think in his bones. Yes, I think he did have it in his bones. Anyway, he's just gone totally into exercise after we did the PP, and he's been lifting weights, and he's been going for 2 hours every morning, 6 mornings a week. Fantastic. And he's got it out of his, we've done a few other things, obviously, but he's got it out of his bones and out of his lymph. And the hospitals say they've never seen anything like it before. And they're now going to give him radiotherapy to knock it out of his prostate.
Yeah, that's good.
He says, they take it backwards. But I think it was the exercise more than anything else that did it.
If you get time, you should chase a guy called Professor Rob Newton from Perth in Australia, who's one of the leading experts in exercise and prostate cancer. And he's leading, along with Stacey Kenfield, who I know very well from California, called the Interval Gap 4 study, which is randomizing men into an intensive exercise program with metastatic prostate cancer and evaluating tumor outcomes and reduction in inflammatory markers and oxidative stress and all sorts of things. And we're involved in that in Bedford and Cambridge. but it's an international study, and he's a real expert, and he really explains why exercise has an anti-cancer property.
Well, I will tell you now, one of the first things I say to men is that, but you may or may not agree with the whole thing, but I say, look, there's a kind of Bermuda Triangle in prostate cancer, and it's got diet, it's got fat control, and it's got exercise as the three corners of it. And it's not exercise, it's vigorous exercise. And that comes out of my American patients. So I've even got one who's in the American seniors volleyball team, but I've got men at 70 and they're down the gym all the time, you know, and they're doing it fabulously well.
I think you've hit the nail on the head there. I mean, look, walking around the park, you know, looking at the petunias is good. It'll stop you getting a blood clot and maybe help with weight reduction. But if you read, you know, Rob Newton's data, you know, you have to get a bit of a sweat on. You have to feel a bit uncomfortable, I'm afraid. And that what that does is it reduces inflammatory markers, it improves oxidative enzymes, improves gut health, improves mood, the circadian rhythm, the list goes on and on.
Yeah, I know.
It also helps gene expression. It alters the expression of the genes we're born with and the genes within cancer cells. So it is an amazing anti-cancer treatment. Not for everyone, and doesn't work for everyone, but it works for some very well.
You're talking to a fully qualified personal trainer. Be careful. Now, Karen Bailey asked this question, must be about her dad or something. Is having your specific prostate cancer DNA tested worth it? I've never heard of it.
What she's probably referring to is, well, all cancers come from the genes, doesn't it? It's a mutation within the gene. We might have been born with a susceptibility, but something which happens, it alters it. So you get mutations in our genes, which we're carrying around all the time. We also get further mutations in the cancers themselves. And as the cancer gets older, you get further mutations. Now, obviously, the future of oncology is to target these specific mutations. So Herceptin for breast cancer, for example, targets the HER2 over amplification. And you target that, and it works very well in telling that cancer cell to stop growing and stop dividing. And it's an amazingly successful drug. But of course, you know, in 5 years' time, I will be surprised if I'm giving much chemotherapy at all. It's all moving over to these targeted, very highly technical things, which makes, you know, oncologists' life difficult for the right reasons. So yes, we have to look at, we're constantly now asking the pathologist to do, can you test for, you know, BRCA1 or BRCA2 mutations? Called, you know, the classic one is a new drug called olaparib, which is for breast cancer. It only works for, well, in prostate, it only works if you've got the BRCA1 or BRCA2 mutation. So you have to go back and test that. And it works very well in those, but it doesn't work at all well if you don't have the mutation. So that instead of in the olden days, you give the same drug for everyone, you bespoke drugs for different people based on their DNA profile. That said, running off to Germany and getting a list of, you know, 150 DNA mutations and then plonking it on my desk, which does happen, probably happens to you a lot as well. I say, well, I've only got these drugs available. Okay, so you know, I've only got olaparib. So I only need your BRCA1 or 2 mutations. If you have it, you can have olaparib. If you haven't got it, you can't have it. And also, olaparib is only available privately. So if you're not privately insured, it's going to cost you £100,000 a year for this drug. So, you know, you've got to think of the end point.
I mean, this is exactly what I say. People come to me and say, if I go and get my genes tested? I say, look, if you go and get your genes tested and you come up with 10 mutations, I don't know what will go against them. And I bet the doctor doesn't, because he hasn't got the drugs. So, you know, we're not there yet, is what I say to people.
Well, we are. Yeah, I think you need to look at the drugs first.
Yeah.
And then work backwards.
Yeah.
You know, as I say, the classic one this week, I had 2 men with prostate cancer. I wanted to give them olaparib. It's not funded unless you've got the BRCA1 or 2 mutation. So you go and do those tests. Roche, for example, in their liquid biopsy, they don't just do BRCA1 or 2, they give you 50. So we've got 50 now. The hope is within the next couple couple of years, there might be another drug coming, well, there will be another drug coming through, which is targeting one of the other mutations. And you've got that information available. So it's useful to have it if you're going to do the test, so to speak. But, you know, people saying, well, you know, should I be taking turmeric because I've got a BRAF mutation? You know, we're really not there yet on that level of information.
Yeah. I think I know the next guy. I think this is nom de plume. Jim Zielinski. My prostate cancer is in my bones. The doctors want to give me docetaxel. What about lutetium-177? Is it worth the money?
It's expensive. I've got 4 patients on lutetium now, and they have to go to Windsor for it in the UK. And they've done well, actually. You know, I was quite surprised. I mean, you know, these people were pretty much end stage, advanced, you know, lots of other treatments. And they've done well, they've tolerated it well. So I'm quite impressed with it, because you know, my research 20, 30 years ago, I was doing radio-labeled antibodies, so I'm used to this. So it's nice to see things coming through, which is working better. You know, when you have metastatic prostate cancer, there is a pathway of management. You know, you need androgen deprivation. After a few years, that stops working. You need your enzalutamide, abiraterone, another category of drug. They work very well for a few years. Chemotherapy can work for some. I've got a patient who's been on it for 2.5 years and his quality of life is fantastic. I've had other people, you give one cycle and their life falls to pieces. Yeah. So you need a good oncologist to monitor the patient and correlate the toxicity, quality of life and outcomes. So it's not as easy as should I have it, shouldn't I have it? Yeah. And then after that, if you're privately insured, you can have the lutetium or olaparib if you're BRCA1 mutated. So there's always a pathway to go through. If you've had everything else, it's worth a try of the docetaxel. Start with low doses, monitor it carefully, and be prepared to stop it if it's not suiting you. But it's not, you shouldn't really say no to anything if you've tried the others.
I was in Starbucks in Bumrungrad Hospital, which is our #1 in Bangkok, because I have a hearing problem. And this chap jumped out at me, you're Chris Woollams, you know, whatever, I get your newsletter, believe it or not, in Bangkok. And I said, what are you doing here? And he said, we sat down, he said, I've got prostate cancer, it's in my bones and everything else. I've just been to the Philippines and I've had lutetium-177. And he said, and they're monitoring it for me here. What's going on? And in the Philippines, it's 2,000 quid a time. And I looked it all up on Royal Marsden and it was 7,000 quid a time. So I can
know where to come.
Pardon? It's a long way to go, and I think unless you've got your vaccine passport, you can't get there at the moment. Yeah. Okay. Then there's another one from Ken. He said, if I'm not mistaken, you use broccoli in POMI-T. It contains indole-3-carbinol, which denatures estrogen. I get all this all the time. Charles Myers in the USA. You know who Charles Myers is?
I've heard of him, but remind me.
All right. Charles Myers, his nickname was Snuffy. And Charles E. Myers has actually launched about 6 drugs in his time, AIDS, all sorts of things, and cancer. And he went and got prostate cancer himself. He treated himself with some of his old drugs. One was Suramin, I think, put me on the spot now. And he formed the Prostate Cancer Forum. And I actually had a guy who went over to Myers, and he'd had cancer, it got into his bones, lymph, whatever, and he went over to Myers, and Myers, I think this is what the question's about, gave him 2 off-label drugs, LDN and dutasteride, the anti-estrogen, and cured him. And this is how Myers cured himself. And the guy came back, had 6 years free, came to me because he got it back and everything else. And I basically said, what happened last time? He told me. So I sent him to somebody to give him those things. It worked once, why not try it again? It did. But I'm no oncologist. So I always send people to oncologists, people like yourself. Anyway, the question is, Charles Myers in the USA uses dutasteride against estrogen. Is cutting estrogen a good route to take against prostate cancer?
Right. Right, there's a lot of questions there. First of all, the broccoli. What we did, we look at all the previous studies. There was a study in Norwich which gave people broccoli before their prostatectomy, and they showed that broccoli altered gene expression. So it dampened down the genes which tell cancers to grow fast, and they encouraged the genes which told cancers to switch off. And that was measured objectively, so that's why we included it. Broccoli does contain 5-indole carbinol, and it can have effects on the estrogen pathway. It's very minor, and we measured testosterone levels in the study. It didn't change at all. So I don't think that pathway was influential, certainly within the doses within POMI-T. And we certainly wouldn't discourage, women with breast cancer or men with prostate not eating broccoli. It's quite the opposite. The other polyphenols have enormous benefits. They encourage antioxidant enzymes to be more efficient, so they switch them on when they're needed and switch them off when they're not needed. They have an anti-inflammatory effect. They help gut health because they act as a bit of a prebiotic. So everything's going to have a slight plus and a negative, and the negative of the slight estrogenic effect is not relevant there. Coming back to the question of estrogen, now, when we didn't have any other drugs, we gave estrogen for prostate cancer. It was called stilbestrol, right? The reason why it worked is it actually dropped your testosterone level by a fact called negative feedback. So you give estrogen, the body sees a sex hormone, reduces your LH and FSH, and you reduce your testosterone. So it was actually probably the reduction in testosterone why it worked. And we still use stilbestrol actually, if there's nothing else to offer. And it works very well for some people, but it does cause a pulmonary embolus in about 20% of cases, which can be fatal. So it's not a good side effect to have.
No, not really.
But if there's nothing else around, dutasteride is actually a very mild anti-estrogen. The way it works is it affects the metabolism of testosterone. So actually, sorry, I'm taking it back. It's not an estrogen. It actually affects the metabolism of testosterone. So it reduces very slightly your testosterone levels. And we use it for benign prostatic hypertrophy. And we use it for hair loss. Donald Trump took it for his hair loss. And it was, well, anyway, that's a different question. And people use it around the world for hair loss because it just reduces your testosterone slightly. There was a big trial, several big trials to look to see if it would help prostate cancer in the early phases. And it didn't actually. In fact, there was a slight worry. It increased high-grade prostate cancer. And we don't know why. And so it's not licensed for early prostate cancer because of those trials which were done.
I think that was the other one. They did it in Australia, if it's the same trial, and they used finasteride and dutasteride.
Yeah.
And both actually brought benign prostates down, but the finasteride turned on more prostate cancer, so they dropped the whole trial.
It's debatable whether it did do that, but the number of high-grade prostate cancers was higher. It could have been, as I said before, that you just gave people a bit of a false reassurance because the PSA dropped a bit and they perhaps, it was masking an underlying cancer. I don't think it actually caused. So
you're not sure that Charles Myers dutasteride is doing the trick?
If you've got metastatic prostate cancer, well, it could take the edge off it a little bit, but I don't think dutasteride would have a major effect, to be honest, if that's the only treatment. But I'm sure that wasn't the only thing he was taking. I think it was the other drugs.
We'll leave it there, I think. I've got a question from Alison Merrick. Can you tell me how to get high dose melatonin in the UK? I think the simple answer to that, Alison, is to email chrismeanshealth at gmail.com and I will tell you. Okay, next one. You have a book, How to Live. Tell me about your book.
Thank you, Chris. Good plug.
No, that's not you. You need it.
Yes, well, it's very proud of that. I mean, basically, I've written lots of evidence reviews and done over 100 research projects for the last 20 years, but they're all in a sort of medical type jargon and trying to direct it to doctors if they could be bothered to read them. But that information really is most important, like your book, is to go out to the general public and to people who want to empower themselves with their own health. So obviously it was better to rewrite it into a book for the public. Saying that, it's got over 500 references. It's quite useful for medical students and nutritionists and people like that, because it's a little bit more than just go off and run and take some broccoli. So I was approached by one of the publishers, and we did it. It took 3.5 years. As you know, it's not an easy task to do a book.
No.
It got #1 on Amazon for a couple of weeks, so I was very pleased with that. And so it's fairly popular. But it's just really, it's not meant to tell people how to live. I don't like the title, but it was just what the publishers came up with. It's just to sort of tell people, why certain foods help, what you should be avoiding, and try to explain the underlying mechanisms. Because in our opinion, people are more likely to do a behavioral change if they know what they're doing is likely to work. And it doesn't go on about different foods. It doesn't say about how you should cook. You need a cookbook for that. It's more about what ingredients to have.
Okay, all right. Amy Richards says you like polyphenols for cancer, or rather against cancer, I think. Does no drugs work? What are the best polyphenols for triple negative breast cancer?
I think she does. No drugs work for triple negative breast cancer, she's saying. We give a lot of chemo for triple negative breast cancer, and you do get fantastic responses. But as she's probably alluding to, patients often relapse, fairly quickly afterwards. So it's your definition of whether it works or not. You certainly see a response. We are now using olaparib, which is and that we're getting. I've got a patient, my first patient's on it for metastatic breast cancer with a BRCA1 and 2 mutation. She's doing really well. In fact, she's now going off. She's got a job in Nigeria. She's tolerating it well, leading a completely active life. So there are drugs which work. So you just got to suit them. We know that exercise can improve BRCA1 and BRCA2 mutations. So the Angelina Jolie type gene. So obviously exercise is a good thing. There's no study of a thing like POMI-T for triple negative breast cancer, but there are studies showing that lifestyles which enhance your polyphenol intake are good, but none of them are sort of randomized. If I had triple negative breast cancer, or if I say to my patients as part of the general spiel, I would certainly increase intake, because there's so many benefits across the board for them. Even the phytoestrogenic ones like soya, because the tumor isn't estrogen receptor positive, would be completely safe. So really, to have smoothies with celery, ginger, turmeric, maybe take a supplement as well, I would highly recommend. And it also would improve your how you feel, because they improve gut health, they help joint pains, they improve mood. So they would be recommended. Whether they'd have a significant reduction in the progression of cancer is not being proved.
Okay, all right. I've looked at the epigenetic factors. We'll talk about it sometime. The epigenetic factors in TNBC. I have a lawyer. She hasn't sued me yet. She actually wrote to me about a year ago now and said it's 10 years ago since our PP, and she's literally done it by diet, diet and exercise.
It's very reassuring. I mean, I do a case report of a person who comes in with an early cancer, but is on. The patients often say, I'm on the usual, doctor. The usual is a statin, an antihypertensive, an indigestion medication, a laxative, painkillers for my joints, an antidepressant. If you can get people off those, the cancer often, as a sideline, gets better.
Well, I feel very guilty, right? I am not a doctor. I tell people I am not a doctor, and they come to me. I had a lady with TNBC, lung cancer, and she's on 8 drugs. She's never been in a cigarette in her life. She's about 63. She's on 8 drugs. And my first reaction was, well, you've got this, probably because you screwed your gut up because you're on 8 drugs. It's kind of a downward spiral. You were ill, so you took these drugs, so you made your gut worse and you became more ill, and you just go down the plug hole. And it was like, I can't say, can you get off these drugs? But actually, that's what you need to do.
Well, yeah, it's a slow process. I mean, this particular man I was referring to I had the good fortune to see every 4 months to monitor his prostate. So, you know, to stop an anti-indigestion is not going to happen overnight. So you need to give advice to improve gut health. You know, eat more kimchi and live foods, eat more prebiotics, and eventually then you can take them off the antacid, which of course improves.
You test people for Helicobacter pylori?
I don't.
About half the people who get acid reflux have got Helicobacter pylori.
That's correct. And if you suspect that, you can do a specific course, but we know that polyphenol-rich foods and some probiotics can help with that. So it's usually we're guided by the symptoms. If the symptoms go, you've probably got rid of the Helobacteria and improved gut health generally. I'm very keen on probiotics at the moment, looking at the role of probiotics to support well-being, how you feel in your gut, to reduce chronic inflammation, and probably to improve, well, not probably, we know they improve the outcome of oncology drugs now.
Yes.
I mean, this is now being looked at.
You're joining the fight. This is where I've been, because an awful lot of doctors have told my patients and the nurses, you don't need a probiotic. It's, waste of time. It's all mumbo jumbo. But, my first article was in 2005. I'm a Rolling Stones fan. I wrote an article about colorectal cancer. It was called Mother's Little Helpers. Believe it or not, it was all about your gut, how the gut give you colorectal cancer or prevent it.
Yeah, you're ahead of your time, Chris. I mean, last year in ASCO, 2 years ago in ASCO, the head of ASCO turned up and said, after a trial in MD Anderson, where there's a drug for one of these targeted drugs for melanoma, and they work really well, these drugs now, from people who have got 3 months to live, going into remission. And there's a 40% improved response rate if you have a good gut health, because they work by recruiting your own immunity to fight the cancer. So if your own immunity is not on par, you're not going to be able to fight the cancer. Okay,
you've hit a hobby horse of mine, so we'll just digress for a moment because everybody will be interested. So I get people, for example, and they've been given Taxol and carboplatin. So they've been given those for, say, 4 or 5 months, and then Avastin is added in. So now they're on 3 drugs and they're given those for another couple of months. And then the Avastin is allowed to run for a couple of months. And then the doctor goes, I'll tell you what we'll do. We'll try a PD-1. So he's going to try an immunotherapy like pembrolizumab or nivolumab. My immediate reaction to the patient is, right, this man thinks they're a drug. They're not a drug, they're an immunotherapy. Therefore, could you ask him if you can have 3 months off between the Avastin and the immunotherapy? Because I need to rebuild your gut. Because all the research, Chicago and places like this, is very, very clear. For example, people who eat the highest levels of soluble fiber when they're having their immunotherapy drug get much, much better results from the immunotherapy drug. It's bloody obvious why, because it puts up your good bacteria and you need those, because on the box, it says unblocks your T cells. So you need lots of T cells.
Yeah. No, I'm glad you say. I mean, you're into the realms of prehabilitation.
Yes.
And there is a program in Britain run by the Royal College of Anaesthetists. It's a prehabilitation program. I was on that committee. I was a bit disappointed they weren't talking about diet very much. It was mainly about exercise, but at least it's a start, getting people to prepare themselves. And there was a very good case report of someone who went on a PD-1 inhibitor. She had it, fell to pieces, ended up in intensive care with pneumonitis, profuse diarrhea, which was almost fatal. But saying that, even though she was only on it for a month, she had a good response. So she stopped. And then on herself, she then did what you're suggesting. She changed her diet completely. She exercised, she improved gut health. She then restarted it 3 months later and was able to tolerate it completely because she'd prepared herself for it. But why didn't they do that the first time?
Yeah, I know. I just think that, I'm sorry, it sounds a criticism, but I just think all too many doctors treat PD-1s as another drug. They don't kind of understand exactly what they're trying to do. I mean, you know, you've got to remember the doctors have been using gut health for 2,500 years. There was this chap called Hippocrates, I think in the past, you may find, who actually said all illness starts in your gut. And he used to treat the gut. Susie Whitehead said, oh, here you go. How do you know if your gut is healthy and your immune system is working? How do you know if someone's immune system's working?
Well, I mean, the fact you're alive, because we get attacked by bacteria and viruses 24 hours a day. So if you're alive, it is working to a certain extent. It may not be working as efficiently as you want, which I think is what the question is saying. I mean, you know, there are measurements. You can do breath tests and fecal samples, but you know, at the end of the day, I mean, I've been doing COVID ward round every 3 times a week since COVID started, because I now run the national nutritional intervention study for COVID in the UK. So, you know, I do a ward round. How have you been, sir? You know, you've got COVID now. How have you, you know, how's your guts generally? I'm not blaming anyone for getting COVID, but I'm just saying there is a correlation between poor gut health, that's for sure.
Yes.
And they say, I feel bloated. I have, you know, I'm constantly flipping between diarrhea and constipation. I'm on and off laxatives. I'm on anti-indigestion medication. I just don't feel right. That is a sign your gut is not good. And that's probably the most reliable. And I would say that's more reliable than going off and having a fancy breath test.
I agree. I agree. I think you know when you're not well inside you. Lisa Lilly says, do you have any tips for post-treatment on HER2 breast cancer? I've quit my treatment as I felt awful, and now my oncologist is pressuring me to take tamoxifen instead. I think she must have estrogen driven as well. I feel so well with no drugs, so want to remain so. Should I be concerned? I'm 43.
So what we're talking about there is adjuvant treatments. This lady would have had her breast cancer. She would have had it removed surgically. She probably would have had some local radiotherapy. She would have been HER2 positive and had a year's Herceptin. A year's Herceptin will halve the risk of relapse in the rest of the life. So I would definitely have that. What she's referring to, the tumor must have been estrogen receptor positive.
That's what I would.
Should she have then adjuvant hormones on top of what she's already had? Now, there's various programs to look at the likely percentage benefit you're going to get. What if she took, say, tamoxifen for 10 years or an aromatase inhibitors? There's a program you can put in. It's called Predict NHS Breast, and it will give you a likely, we don't know for sure, but a likely percentage. So she might be getting, say, a 4% or a 5% reduction in her cancer coming back in her lifetime. Now, most people say, well, I'll take that 5%, thank you, you know, because I would have had 10% from the chemo, I'd have had 20% from a Herceptin, I'll have another 4%. If you add them all up, you've gone from a chance of dying of 60% down to a chance of dying of, say, 15%. So it's worth it. But you've got to then correlate your quality of life against that extra percentage. And it could be she takes tamoxifen, she feels dreadful, she has hot flushes, mood changes, joint pains, weight gain. And then you've literally got to sit down and talk to people like yourself or your friends and say, is it really worth that extra 4%? And I have this conversation every day with people. And I say, and quite often I say, look, to be honest, I don't think it is. You know, you've done well, you've had all the other treatments. Let's maybe not go to that extra step. Other people who are getting a really high benefit, I might push them and say, come on, you are really getting a big benefit from this. I would persevere and do lifestyle changes to help you tolerate it. And many doctors don't go down that route. As I said at the beginning, we did a study in Tokyo recently with the Women's Breast Cancer Survival Group, and they were looking at various supplements and activities to improve their tolerance to hormones. And, you know, exercising regularly, getting some sun in the morning, improving your circadian rhythm, stopping smoking, and certain supplements. The POMI-T supplement, because it's got all these anti-inflammatory and very healthy drugs, showed a response in 60% of women at about a 20% level of benefit. And for them, that was the difference between being able to tolerate the drugs or not. So I would, first of all, my advice would be look at some lifestyle measures. exercise, all the things I've just measured, maybe take the POMI-T supplement or other similar ones. If those don't work, then the next step is to ask yourself, you've got to look at the overall quality of life. And if it's not good, or if it's even preventing you exercise, it might actually be doing more harm than good.
Yeah. Okay. Actually, we're talking about supplements and things. Elizabeth Kay, I think she's in Canada. She said, my hospital pharmacist warns me not to take turmeric, milk thistle, green tea, alpha lipoic acid and coenzyme Q10 with Ibrance. She said, so I rang Pfizer and they say they're all perfectly acceptable. Who do I believe?
There is a knee-jerk reaction from doctors and pharmacists say, don't take this. I've been hearing you shouldn't take turmeric with your chemotherapy. I mean, it's ridiculous. And often people are misinformed. I mean, I was really pleased with 3 studies in ASCO where they gave turmeric with chemotherapy. And, funny enough, it actually improved outcomes.
I've got all the research.
Yeah, so people just haven't read them. We are worried a little bit about some supplements. So, for example, vitamin A and vitamin E are direct antioxidants, and they probably, well, not probably, we're worried they could interfere with some of the effects of the drugs. It's mainly because of misinformation, I have to say, and the safest place for those doctors and pharmacists to be is to say no.
Yes.
But it's just because they're not particularly well informed. There are some, I mean, I would certainly recommend a probiotic. I've got hundreds of patients who've been told they shouldn't take probiotics when there are 3 studies to show that if you take probiotics during your chemotherapy, you have a less chance of diarrhea. So they just haven't read the data. That's the answer.
There's another one about reading, okay? Because this comes up to me all the time. Heather Schaefer, why do oncologists give women Adcal or Calcitu, large amounts of calcium with no magnesium, no phosphorus, and little vitamin D? That won't strengthen my bones. I did a show on vitamin D. My son interviewed me. And I thought, well, I better check what I say to people is correct. And I went to American Bone Health, which is a government body, and I get it absolutely right. And no oncologist ever talks about magnesium or phosphorus alongside the calcium, the vitamin D and Adcal's way too small. Why don't they?
Yeah, that I've got a bit of a bugbear about Adcal as well. If you're on a bisphosphonate, a bone hardening drug, it does drop your calcium levels quite a lot. Yeah. And we need normal calcium levels. So you do need something like Adcal or calcium if you're on a bisphosphonate. So let's just take that out of the way. That's a different setting.
Yeah.
People are often just stuck on Adcal, if they're on aromatase inhibitors or if they're worried about bone health. The BMJ did a meta-analysis of Adcal. Well, I'm blaming Adcal, drugs with calcium and vitamin D combination. There's lots of different. And they showed no benefit for bone health. So that was in the British Medical Association journal, the BMJ, one of the best in the world, showed no benefit. Yet people are still being prescribed all over the world every single day. So that's odd. The other trial, also in the BMJ, showed that Adcal increased your risk of heart attacks. So we've got one trial saying, one meta-analysis saying it doesn't work, and the other one saying it increases your risk of heart attacks. It's still being prescribed every single day.
I know. American Bone Health, very good site. It says that too. It says that too. I mean, I talk about people, American Bone Health says, if you're in fear of osteoporosis, having chemo or not, it says your total intake of calcium should be 1,500 milligrams a day. Your vitamin D should be 2,500 international units, which is about 62 micrograms. And you should have magnesium around 300 milligrams, and you should have a couple of helpings of beans. Well, I use lentils. I say to people, women have a couple of helpings of lentils. And that is a package that gets calcium into your bones.
Well, exactly. I'm glad you mentioned the pulses, because you do need protein, but it's actually plant protein is better for bones than animal protein. You didn't talk about vitamin K2.
I use it all the time.
Yeah,
Sorry, I apologize. Go.
no,
Yeah.
there's, I mean, there's still work to be done, but it's very encouraging that vitamin K2 does encourage the calcium to get to the bones and not in your coronary arteries. So if I was worried, I would take a vitamin K2 supplement or have foods with vitamin K2 in it, like beans, pulses, mature cheeses,
You need
Stilton.
gut bacteria.
Yeah.
Bacteria to release it. We recommend K2 because it does protect the liver, it protects the bones, it helps the bones. And actually, this got another piece of research on it. It says it makes chemo more effective and for longer. Did you know that?
Well, it may do. I mean, I'd like to.
May do.
I would. It is a big, broad statement that I think.
Yeah, I think so too. All right. This is a lady in America. I can't take aromatase inhibitors because of bone pains and hot flushes. Oncologist in America, he came from Chicago, I remember, invented myomin for women who couldn't take.
Yeah.
I don't really know. It's sort of, she's equated it to POMI-T. It works. It reduces estrogen. Myomin is 5 Chinese herbs because the guy she's talking about, the oncologist, is actually half Chinese. And it's 5 Chinese herbs, 2 of which I looked up and they're excellent for reducing estrogen. 2 are okay. 1 I couldn't find anything on, but he's the Chinese herbalist, not me. Do you know anything about myomin?
You've got to be very careful about things. I mean, yeah, it might work, but the studies for whether aromatase inhibitor helps people with breast cancer involved hundreds of thousands of people across the world, and you're only seeing about a 4-5% benefit. So, you need to do massive studies to find out if these things actually work. And the myomin might reduce estrogen slightly, but you don't really know it works. I mean, there are drugs you can take with your aromatase inhibitor. Well, first of all, if you're on an aromatase inhibitor, stretch every day, exercise every day, reduce your weight, stop smoking, improve your gut health, take a polyphenol-rich diet or supplement. Those are the things to try first. If those don't work, then going on to a Chinese herbal medicine, yes, it might work. And there probably is some data. I would be a bit nervous about it. If I'm only going to get a 4 or 5% benefit, I'd probably just make the lifestyle choice not to take it at all.
I've got a question from Patricia Jones. She said, in a recent blood test, I get asked this all the time, my lymphocyte count is low. What do you think I should do about it?
We look at full blood counts every day, and we look at the neutrophil count, we look at the total white cell count, and the others bounce around all over the place. So we don't really we worry if they're too high, to be honest. The lymphocyte count, because it could be a sign of an early leukemia type picture. But there's not a lot of correlation between the actual value of these things and whether you're going to get an increased risk of cancer or infection. In fact, many of the CD4/6 inhibitors we give for breast cancer are dropping the lymphocyte counts quite markedly, but patients don't seem to have an infection. Whereas if you drop it with chemotherapy, they get an infection tomorrow. So the absolute value, I wouldn't worry too much about, unless there is a history of increased risk of infection. So just do the things which help your immunity: exercise, eating well, gut health.
You can correct me if I'm wrong. Women come to me, or men come to me, and they've got their blood scores, and they fuss, they worry about it.
Yeah.
And I say, look, this is really the doctor trying to find out how ill you are, because if you're ill, then he can't give you the next round of drugs. I'm not being negative. That's what it's about. And I said, if he's happy and he's going to give you the next round of drugs, that's it. I'm into wellness. I'm into a different issue really about your fat and your sugar and things like this. So I almost push it to one side. I think it's not something. I mean, I wouldn't start giving people herbs or things like this to put their white cells up. That's correct, isn't it?
Yeah, I think you're right. I mean, it's the end result you want to look at. I mean, I do get people coming to me with chronic low white cell counts post, say, chemotherapy, which is never recovered properly. And it worries them, especially with COVID and things around. Are they going to be more susceptible? And, you know, the bottom line is I do exactly what you say. You try to restore gut health and do things which will improve immune efficiency. And this is what the important point is. It's about immune efficiency, not boosting the immunity. If you boost your immunity, you're going to get an allergy, an autoimmune disease, or even diabetes or anything which is immune related. You want the immune system to run efficiency. So to have counts a little bit below par, you know, as long as you're not getting infections or things, I wouldn't worry too much about it. Just try to help your whole body.
I have a last question. Julie Thompson says a CT scan showed up some lytic lesions. Oncologist is rushing me off to have more scans. Are lytic lesions a sign of an active cancer?
Well, it's usually, we call metastases lots of things. You know, we call them hot spots, we call them, you know, lesions, we call them lytic spots. So yeah, what it means is he's concerned about something, but he's not quite sure what they are, and it needs further investigation, I suppose.
So what haven't we covered?
Well, I haven't covered the COVID studies I'm doing, but probably that's another thing. We're giving my latest trial is giving a probiotic called Your Gut Plus to patients with COVID, and we're seeing if that randomized, and we're seeing if that improves the recovery and prevents them going into long COVID syndrome. And we're very pleased. We've recruited 150 patients for that. In that trial, we're also doing a sub-analysis of a phytoestrogenic supplement, which has various things, chamomile tea, citrus bioflavones, and it's called the overall thing is called the Phyto-V study. So if anyone want to look it up, it's called the Phyto-V study. And we're very excited about the very positive outcomes we're getting when we restore. Basically, it's all featured on gut health, reducing excess inflammation, improving oxidative stress, all things which are very important if you catch COVID, mind you. So we're very excited about that, and we'll have the results quite soon, I hope. And from that study, we've moved on to a vaccine. I won't go into vaccine, I'll just mention it. We're looking at ways to enhance the effectiveness of the vaccine. In other words, preventing side effects and improving antibody titers. And there's lots of evidence that vitamin D, exercise, and probiotics can do that, but it's not been proven in COVID. So we're just going into a study where we're randomizing people to have the Your Gut Plus probiotic, plus an exercise program, plus a vitamin D against standard care. And we're seeing how that influences the vaccination. There's lots of evidence to show it helps other vaccines like the flu vaccines, not for the COVID vaccine. So we're moving out of cancer into general health, and we're moving out of general health now into COVID, because that's obviously the elephant in the room, which we need to address as well, which is lifestyle related in some cases.
Right. I'm going to sort of wrap this by saying one thing. One of the things I always say to patients, well, not always say, but doctors treat them. So you get women with breast cancer, and they have, in some order, they have surgery, FECT, for example, they have radiotherapy or whatever. And usually at some point along that line, the doctor goes, right, okay, that's the basic 6 months, whatever. And, you know, we'll scan you every 3-6 months and whatever, and off they go. I always say to patients, when that man lets you out of his room or woman lets you out of his room, that's the time to start. That's not over. Your cancer fight is not over. You now need to start. Because I've tried to do things before, if they've come to me before, but usually they come to me pretty well after, I mean, towards the end of it. And I say, now's the point where you've got to rebuild the body. You get cancer because you've built a body conducive to cancer. What I want to do is build your body conducive to health. And exactly. You get people going into upward spirals. That's my view of cancer.
Chris, that is fantastic. I totally agree. But it's not just about cancer. What you've just said is about arthritis, risk of dementia, risk of COVID, risk of, you know, any chronic disease. So
all right,
yeah.
All right. I said it was the last question, but here's the real question. Why is it that vitamin D causes so much controversy? There is research from the year 2000 and from 2010, two very big studies, meta-analysis, that shows very clearly that your innate system's got T cells and you have to have vitamin D stuck to them for them to attack. And your dendritic cells need vitamin D for them to pass the bad guys over. And your B cells need vitamin D to get the antibodies. So if you don't have vitamin D, you don't have an immune system. What is all this negativity about vitamin D?
Yeah, I mean, I was very shocked when the government, the Gang of Three, stood up last May and said there's no evidence for vitamin D in COVID. I mean, I just couldn't understand where they came from, because, you know, you'd have to take enormous amounts of vitamin D to cause any harm. So it's not, and it's not expensive. So
Yes.
You know, it's not as if they're protecting anyone by saying that. And, you know, in September, when 3 studies showed that people with low vitamin D are more likely to get COVID, much more likely to have the cytokine storm, which is fatal, they're then telling everyone to prescribe it. And I was saying, couldn't they have just said last May, there's some evidence, probably worth taking, it's not going to do any harm? No. So I think that 6 months, nobody's talking about how much harm that would have been done.
Exactly.
The reason why there's controversy, sorry.
No.
We know that low vitamin D is correlated with all sorts of things: arthritis, dementia, depression, cancer. Chemo drugs don't work as well. You're more likely to not get problems with aromatism. But what is less well established, if you then give vitamin D, it corrects it. Because the large studies which are done randomizing vitamin are very difficult to do, because in the control group, you get people taking the vitamin D, which dilutes the stats answer. They don't measure baseline vitamin D levels. So it's actually probably only works well for people with inherent low levels. So then they publish a paper, the press take hold of it and say, no evidence of vitamin D helps. No, what they should have said is that in that particular trial, which wasn't particularly well designed, they didn't see a positive result. But of course, the headlines just say, doesn't work. This is what the press. And it's also how you take the vitamin D. For the vaccine study, we're putting vitamin D with probiotics, because we know if you can improve gut health, vitamin D is absorbed much better in a much more bioactive thing. So, you know, there's not been enough research to show that the supplements benefit, and that's the problem. It's they are very likely to do so, and other measures to improve vitamin D, like regular sun, which doesn't damage your skin, you know, vitamin D rich foods. But that's what we need to do. We need to do the research to convince the naysayers how important vitamin D is.
Butyrate. Look up butyrate.
Absolutely.
Okay. Butyrate. All right. Well, look, thank you very, very much, Robert. It's been very kind of you, very interesting. I'm sure everybody will get a lot of benefits out of this. And please do come back on our show anytime. I've enjoyed thoroughly talking to you. It's, as I said to you, it wouldn't be an interview. Our next show is Professor Carol Sikora. He's, I believe, Professor of Integrative Oncology in Buckingham University. So we're keeping the integrative oncology theme going. Professor Carol Sikora, I'm a big fan of his. He's seems to be professor of everything. He was head of the WHO at one stage. He's led Genesis Care. He's now heading a proton. He's a busy man, and I've got an idea about something I'd like you, me, and him to talk at some point, but that's another story. All right.
Well, I tell you what, sorry to interrupt. I need to say this. Next time you can come and invite me to your house in Thailand, and I'll do the interview over there. Okay, no problem at all. All you got to do is have a vaccine passport. So which one are you taking? Can I ask? Well, it's pretty much compulsory to have the vaccine. I actually had the Pfizer one because that's what I was offered. I can't really see there's much difference between any of them, to be honest. I think the important thing, if you have the vaccine, is to go for a run beforehand, take some probiotics and vitamin D, and then you'll be fine with it. Yeah. Okay. Well, thank you very much. Thank you very much for everything. It's been really kind of you, and I hope to see you again soon. Okay. I'm going to go back out in the sun. All right. Bye. Bye.